Hello, I'm Dr. Brian Cole from Rush University Medical Center, and this talk is on predicting the irreparability of a massive rotator cuff tear. It's an interesting concept to actually predict repairability because irreparable tears may actually be anatomically repairable, but physiologically irreparable. Steve Burkhardt once coined the irreparable tear is like the undrinkable beer. In fact, most tears actually can provide some type of anatomic repair. In addition, there are many solutions which you'll hear about in this session. Our objective is to match the patient's goals. We've learned that rotator cuff repair does not have to lead to a watertight repair, nor to a fully healed tendon to achieve a desired outcome. Repairability can be assessed by a number of factors. It can be done by imaging. In this instance, we see a retracted tear with very little tendon present. We see significant muscle atrophy. And at the time of arthroscopy, essentially there's nothing home to repair. You can see the posterior cuff in place, the subscap still attached, but there's nothing with respect to the supra and the infraspinatus to technically repair. There are a number of considerations that we could consider at the time of assessing a patient, whether or not they have the ability to have an anatomic repair or they have physiologic aspects, these independent variables that may lead to failure. Chronicity is probably the most important variable, and all these other variables tend to relate to chronicity. Certainly tear size, tendon muscle quality, the duration of the patient's symptoms, and there are many patient factors as you see here. Tear size has been quoted as one of the most important factors, and we know that over time, tear size probably increases. In general, the smaller the tear is, the more likely it is to heal. And the larger the tear is, the less likely it is to heal and follow up, whether it's by MRI or ultrasound. Involvement of the subscapularis is also a negative prognostic factor. In this study, when the subscap was minimally involved, re-tear rates were actually quite low. However, with more involvement of the subscap, re-tear rates went up exponentially. Similarly, the infraspinatus is a negative prognostic factor. We see poor preoperative infraspinatus tissue quality with poor clinical outcomes. This will affect us negatively as we go forward, whether or not there's atrophy in an isolated fashion with retraction or in two tendon or posterior superior tears. The infraspinatus is considered a poor prognostic factor. Age also relates to chronicity, and we know that with increasing age, we see an incidence that increases with rotator cuff tears. We also see that tendon quality is stiffer, and we see that age over 65 has demonstrated inferior healing capacity in patients compared to their younger cohorts. Smoking is also a negative prognostic factor. This is a patient of mine who thought it was quite cute to smoke at her first postoperative visit, and I reluctantly agreed to repair her rotator cuff, advised her to quit smoking, but like most of our patients, it's a very difficult thing to do. Well, we know that there are generally worse outcomes in patients who are smokers versus their non-smoking counterparts. Diabetes and obesity are other negative correlates. We know that diabetes is correlated with worse Goutillier grades, inferior clinical outcomes, and inferior microcirculation and stiffer tendons due to advanced glycosylation end products. We recently published a review article in the Journal of the Academy of Orthopedic Surgeons, and we showed that NSAIDs might lead to decreased load to failure when used postoperatively, might lead to decreased repair strength, but really the evidence is insufficient to say that categorically we should or should not use NSAIDs in the postoperative period. And of course, fatty infiltration, as popularized by Christian Gerber and others, has shown that the higher degree of fatty infiltration, the worse the Goutillier score, the worse we do in terms of 6-month and 1-year MRIs in terms of re-tear rates. Fatty infiltration is associated with re-tears and poor function. So when we add it all up, there was a recent study looking at the rotator cuff healing index, and it takes all of these variables, age, tear size, retraction, chronicity, and so forth. In this population of 603 patients is a level 3 study looking at 12-month follow-up by MRI or CTA, and it was a stunning difference between 5 to 6 of these variables, or a score of 5 to 6 compared to those with greater than 6. The percent healed was nearly 70% when we only saw a score of 5 to 6, but when the score increased to above 6, there was only a 37% healing rate. So what are the options? In this session, you'll hear about these options. I think it's important to remember that even repair of massive tears can still lead to a good or excellent result. This is a massive tear that was followed for over 10 years before we electively decided to repair it. And we actually only performed partial repair, as you see here. But this patient within 3 months had excellent function and complete reversal of the pseudoparalysis. The literature is replete with a number of studies that show partial repair of even massive tears can lead to a good or excellent outcome. Later on in this course, I'll talk about the role of extracellular matrix augmentation, but we know that augmentation can increase construct mechanics, improve intrinsic properties of the healing bone tendon unit, can improve long-term incorporation and strength, and lead to lower re-tear rates and improved outcomes. There are a number of systems that are available to us using tacking devices and so forth for dermal augmentation. I'll share that with you later in this presentation. But this is just one methodology using a graft inserter with a 1 millimeter thick dermal graft that's inserted arthroscopically. And then using a tacking device, we can secure immediately at the muscle tendon junction and suture anchors laterally. Superior capsule reconstruction is another method used for the truly irreparable anatomic tear. We know that it can reduce superior translation of the glenohumeral joint when properly performed, and we know the clinical outcomes can be quite successful. We recently reported on why we fail, and we demonstrated that female sex, those with subscapularis tears, increased BMI and reduced acromial interval, have reduced outcomes in terms of PROs. You're going to hear about tendon transfers in terms of lower trapezius transfer as another methodology to overcome extra rotation strength and to improve surgical outcomes, especially in patients who have maintained forward elevation above 90 degrees. You also hear about the subacromial balloon, which is a way to increase the acromial humeral interval and essentially enable patients to be more rehab responsive. The clinical study will be published soon in JBJS and showed substantial pain reduction and improvements in patient-reported outcomes and satisfaction ranging between 45 and 100%. And finally, for the most chronic recalcitrant patients with pseudoparalysis and maybe advanced age, non-intact subscap, glenohumeral osteoarthritis, reverse arthroplasty remains the gold standard in this population. So massive rotator cuff repairs will anatomically fail a lot of the time because it's truly an attritional disease. Anatomy and physiology matter when predicting outcomes, and we can have tears that can be anatomically repairable, but physiologically irreparable. Chronicity pretty much embodies most of the negative prognostic factors, and only some of these are actually modifiable. And there are many solutions for the same problem, and we must individualize treatment with consensual decision-making. Thank you very much.